Hi, my name is Robert DeLuce, and this is my presentation on bariatric surgery. Bariatric surgery procedure. Bariatric surgical procedures cause weight loss by restricting the amount of food the stomach can hold, causing the nutrients to malabsorb. Bariatric surgery works by changing the anatomy of your gastrointestinal tract by physiological changes in your body that change your energy balance and fat metabolism. Candidates for bariatric surgery: have a BMI of at least 40, have a BMI of at least 35 with one or more serious obesity-related conditions, have failed more conservative weight loss alternatives such as supervised diet, exercise, and behavior modification programs, and they are at least 18 years of age. Types of bariatric surgeries: gastric bypass, sleeve gastrectomy, gastric band-in, biliopancreatic diversion with duodenal switch. Each of these surgeries have different advantages and risks. The doctor will determine the type of surgery that will benefit you the most. Gastric bypass. The gastric bypass surgery technique is the most frequently performed procedure in the United States. This technique limits food and keeps it from being absorbed completely. The surgeon creates a stomach pouch that reduces the overall size of the stomach and the amount of food that it's able to hold. The pouch is surgically attached to the small intestine, bypassing the rest of the stomach and the upper portion of the small intestine. The smaller stomach size helps the patients feel full more quickly, which reduces food intake. Bypassing the part of the small intestine reduces the absorption of calories. And here's a picture of the gastric bypass before surgery and after surgery. And you can see the location of the attachment of the small intestine. The advantages of gastric bypass: it limits the amount of food eaten and the desire to eat. It allows the body to adjust to its new healthier set point. Average weight loss is higher compared to any other type of bariatric surgeries. No post-operative adjustments are required. It's shown to help resolve type 2 diabetes, high blood pressure, sleep apnea, and to help improve high cholesterol. Gastric bypass risk. The bypass of the duodenum causes poor absorption of iron and calcium, which can lead to predisposition of iron deficiency and anemia. The bypass can also cause metabolic bone disease. Some patients experience bone pain, loss of height, and a humped back, but all of these conditions mentioned can be managed by proper diet and vitamins. Sleeve gastrectomy. The surgeon creates a small stomach sleeve using a stapling device. The sleeve will typically hold about 50 to 150 milliliters. It is equivalent to the size of a banana. The rest of the stomach is removed. This procedure reduces the amount of food that can be eaten without bypassing the intestines and absorbed. And here's a picture, and you can see how much smaller the sleeve is compared to the stomach. So this sleeve is now your new stomach, and this is also the type of surgery that my mom had. Sleeve gastrectomy advantages: limits the amount of food that can be eaten. It allows the body to adjust to its new healthier set points. The food passes through the digestive tract in its usual order, allowing the nutrients and vitamins to be fully absorbed. It requires no foreign object, no bypass, no rerouting, and a short hospital stay of 2 days. Sleeve gastrectomy risk: complications caused by stapling of the stomach, separation of the tissue that was stapled or stitched together and leaks from the stapled lines, gastric leakage, ulcers, and this is non-reversible since the stomach was removed. Gastric banding. A gastric band is placed around your stomach, divided into two parts, a small upper pouch and a lower stomach. The upper pouch holds 4 ounces of food. This makes you feel full sooner and longer than usual. The level of the food passage restriction can be adjusted by adding or removing saline solution from the band to a port. So here's a picture of the gastric banding, and you can see the access port where you can add or take out the saline solution so the a band becomes tighter or looser. And this gastric banding is known to not be as effective. My mom and dad had co-workers who have had this done, and it has not worked out for them. They had a lot of difficulties with it. So the advantages of the gastric banding: it limits the amount of food eaten during a meal. The surgery can be reversed. No part of the stomach or digestive system is stapled, cut, or removed. Food passes through the digestive tract in a regular order, allowing the nutrients and vitamins to be absorbed. So if you have problems with this gastric banding, it can easily be removed or redone. Unlike the gastric sleeve where your stomach's taken out completely, so you have no other option. The risk for gastric banding: gastric perforation or tearing in the stomach may require an additional operation. Access port leakage or twisting may require an additional operation. Nausea and vomiting, outlet obstruction, pouch dilation, band migrations, and slippage. Biliopancreatic diversion with duodenal switch. This procedure reduces the amount of calories absorbed by the body by permanently altering the normal digestive process. This procedure is considered a malabsorptive procedure. Stomach removal is restricted to the outer margin, leaving the sleeve of the stomach with the pylorus and the beginning of the duodenum intact. The small intestine is then divided with one end attached to the stomach pouch to create what is called an alimentary limb. And here's a picture of the biliopancreatic diversion with duodenal switch. And this is known as one of the most effective bariatric surgeries. Now the advantages: does not restrict the types of food that can be eaten and allows larger meals to be consumed. Provides the highest level of malabsorption. No post-operative adjustments are required. The risk: for all malabsorption procedures, there's a period of intestinal adaptation when bowel movements can be very liquid or frequent. Abdominal bloating and malodorous stool or gas may occur. Close lifelong monitoring for protein malnutrition, anemia, and bone disease is recommended. Lifelong vitamin supplementation is required. Rerouting of bile, pancreatic, and other digestive juices beyond the stomach can cause intestinal irritation and ulcers. Life after surgery. Diet, which is one of the most important parts. When eating solid food, it is essential that you chew thoroughly. You will not be able to eat chunks of meat if they are ground or not chewed thoroughly. Do not drink fluids while eating. Also, do not drink fluids 15 minutes before or 15 minutes after you eat your meal. Omit desserts and other items with sugar listed as one of the first 3 ingredients. Omit carbonated drinks, high-calorie nutritional supplements, milkshakes, high-fat foods, and food with high fiber content. Avoid all alcohol and limit snacking between meals. And here I'm going through a paper that my mother's doctor gave her, and this is just tips for bariatric patients. What to get when you're going to the supermarket. get clear broth, isopure or other sugar-free clear protein drinks, sugar-free jello, cream of soups such as Campbell's cream of chicken and mushroom strained, cream of wheat, skim milk, sugar-free and non-carbonated beverages such as Crystal Light, return to daily activity. Many patients return to full pre-surgery levels of activity within 6 weeks from their procedure. The levels of activity will vary according to the type of surgery that you have. I had the privilege of interviewing my mother's surgeon, Dr. Samir Patel. He completed undergraduate work at Cornell University, earning a degree in biochemistry. At Albert Einstein College of Medicine in New York City, he received his doctorate in medicine, graduated in honor. I'm very thankful for Dr. Patel to give me the time to have a phone call interview with him. It was very interesting to what he had to say, and I learned a lot from him. A few questions that I asked him were, what is the most effective bariatric surgery? He replied with, the most effective is the duodenal switch. However, the most common is a gastric sleeve. The lap band is the least effective and is no longer commonly used due to complications. Next, I asked, how do you determine which surgical procedure to use? He said the determination is made based off the patient's overall health. If a patient is a bad diabetic with medication, a bypass is the most effective. The majority of the patients are very successful with the gastric sleeve. Next, I asked, what is the future of the bariatric surgery? He said he still sees the gastric sleeve being the most common procedure. The field of bariatric surgery is constantly evolving as new technologies are developed. He said he sees the next step to be endoluminal surgery, which is done completely through the mouth with no incisions. It is a balloon procedure that inflates the stomach that is effective for 6 months. Next, I asked, what are the options if the patients regain their weight? First would be to change and monitor lifestyle, perhaps prescribe medication. If the patient is a sleeve candidate, consider a bypass, or if a bypass patient, then consider redoing or rerouting. Next, I asked, what do you like most about your job? He said, in patients like your mom, I enjoy seeing healthy, happy, successful patients. I am able to change a person's life and improve their medical problems in a 1-hour surgery. And when he answered this question, I could tell his tone of voice changed completely. I can tell he's very passionate about what he does. Case study. My patient was my mom, DeLuce. She's 50 years old, morbid obese, hyperlipidemia, and had a BMI of 42. She's at low risk. She's only had 1 positive and 1 negative risk factor, and her goals are to improve overall well-being, lose weight, decrease body fat percentage. My mom's starting weight was 286 pounds, but now, to this date, she weighs in at 210 pounds. Exercise testing, I chose to do a modified treadmill test. This is because after surgery, you're limited of what you can do. So this would be the best fit for her. Exercise prescription. First 30 days after surgery, I'll have the patient do a simple walk program, 3 to 5 days per week, 10 to 15 minutes with gradual increase in duration. And this is just because the patient will still be in pain and uncomfortable. Next, 30 to 90 days after surgery, low intensity of aerobic activity, 3 to 5 days a week, 30 to 45 minutes. And this includes walking on the treadmill, light jogging, stationary bike, and swimming would be one of the best activities for her. After 120 days from surgery, the patient may begin strength training, and this is at low intensity, about 3 days per week, using exercise resistance machines and band work. Conclusion: bariatric surgery is a tool for weight loss. It is important for the patient to do their part with proper diet and exercise. Bariatric surgery is far from an easy way out. There is a lifelong process that will change a person's life forever. This is like what I see from my mom. She's been working so hard with exercising and diet and proper diet. She got her surgery September 21st, and it completely changed her life, and she couldn't be more happy. And here are my references, and that concludes my presentation. Thank you.